Welcome. Our roundtable discussion today is entitled Tricuspid Debate. We're going to talk about indications and the techniques that we use for tricuspid valve surgery. And I'd like to introduce our panelists today, Dr. Pavan Atluri from the University of Pennsylvania is to my left, Dr. Frank Pagani from the University of Michigan is to my right, and Dr. Kevin Accola from Orlando, Florida is to the extreme far right. So I'll begin the roundtable by asking Kevin, for an isolated patient with tricuspid regurgitation, what is your indication for operation?
Well, John, isolated tricuspid valve regurgitation, oftentimes there's some inciting fact that may precipitate that, whether it's pulmonary hypertension, atrial fibrillation, or some other type of valvular entity which may not be bad enough to operate on yet, but has caused or initiated the tricuspid valve regurgitation. So I think the initial thing that I look for is symptoms. Obviously, I'd like to see some right heart pressures and see if there's something that is causing this that I may even make worse. And so I think you really have to step back in those patients and dig a little deeper before you just jump right in and repair or follow them medically in regards to isolated tricuspid valve regurgitation. So I think it takes a little bit more uncovering of possibly other etiologies which may have precipitated it in the first place.
Okay. And Pavan, do you ever try to initiate medical therapy? You know, surgeons are not thought to do that, but sometimes we actually will do that.
I think it really depends on whether we're talking about isolated or concomitant disease.
Okay.
With isolated therapy, I used to utilize medical therapy, but more and more, I think more and more of the evidence is driving us to think about the tricuspid valve much like the mitral valve in terms of the asymptomatic, severe tricuspid regurgitation patient. Because we've all seen the sequelae that results. And so I think it's, once again, a constellation of symptoms. And the symptoms may not be as evident. It might just be lower extremity swelling, you know, the symptoms of right-sided failure. I will admit, though, that, so it's a constellation between the symptoms, the degree of tricuspid regurgitation, and then finally the intrinsic valvular disease. I think I'm a lot less prone to operate on a valve that is not dilated or have intrinsic valvular pathology. So much of the tenets that we utilize from the mitral valve have transferred over to the tricuspid valve. A simple answer, though, is I have not, it's pretty rare for me to institute medical therapy, because usually as surgeons, by the time we're starting to see these patients, it's fairly advanced.
Right. Frank, are there any diagnostic tests that would prompt you to recommend an operation either in the presence of symptoms or without symptoms?
I think the most accurate way of assessing right ventricular function is with cardiac MRI. That would be the best way. Unfortunately, a lot of patients that have other concomitant pathologies, low EF on the left side, have ICDs, and sometimes that option is not available. But in the setting where you can obtain a cardiac MRI, that would be the most informative in terms of both function and size of the right ventricle. And I think those are important considerations in determining timing of tricuspid valve surgery.
Kevin, how about echo? How do you use echo in your practice?
Well, everyone, as was mentioned, usually comes to you at that point pretty well worked up in regards to preoperative examinations. I think the MRI is a great idea in assessing where you are at that point with your right ventricular function and the capabilities of that right ventricle to come back. Transesophageal echo, then we would get to mostly rule out other valvular pathologies, and particularly other pathologies within the heart that may be precipitating the tricuspid insufficiency. So I think you definitely, particularly if it's just isolated tricuspid valve insufficiency, you mentioned a dilated annulus, but I think you have to really dig a little deeper and see what's causing it, because one of the main concerns, and I'd be interested in your thoughts, is they do a right heart cath and they've got moderate severe pulmonary hypertension, which could be treated with sildenafil for a while and see if they get better. There are some options. But those are the patients I think are in a gray zone that sometimes, become very difficult. Not only surgically, they're very easy. You go in and do an annuloplasty remodeling, but their post-operative care or even their recovery period. I'd be interested in John, your thoughts on when you find that pulmonary hypertension, either on an echo assessment or a right heart catheterization.
Yeah, I think pulmonary hypertension prompts me to operate a little bit sooner on patients with TR. Traditionally, the criteria that I use on echo at least are either severe or moderate to severe TR with symptoms, or someone who has an annular dimension of greater than 40 millimeters. I know that's the standard number that many people use. Pavan, do you look at patients who have concomitant disease any differently than isolated? For example, a patient that you're going to revascularize, multivessel revascularization, who have isolated tricuspid regurgitation and pulmonary hypertension, perhaps from LV dysfunction. Do you treat them any differently, or your indications for repairing that valve versus an isolated patient?
Yeah, I think I'm a little bit more liberal. If I'm already going to be on cardiopulmonary bypass, doing a concomitant operation, either in most common scenarios, either concomitant aortic or mitral valve, or coronary bypass surgery. But I think and once again, I think it goes along with the annulus and whether it's greater than 40 millimeters, and also the degree of tricuspid regurgitation. So I think the criteria are probably a little bit more liberal. And this gets back to which isolated tricuspid valve patient do you operate on.
It's interesting, Dr. Conte already declared you were on the far left and put me on the far right. So I may take the conservative approach to that. And I think if you have a normal functioning anatomically isolated tricuspid insufficiency, which is mild to moderate, I'm still a little cautious, if you will, conservative, if you will, far right, if you will, though I've begun to move back towards the middle in regards to when to initiate surgical treatment. Certainly if it's 45 millimeters or a large dilated annulus. But if you've got a pretty normal functioning appearance of a tricuspid valve and not extreme annular dilatation, I think I think sometimes you still need to have some restraint in regards to just putting a ring on everyone. And we say it's pretty benign, but it's another orifice of the heart you're entering. There's a chance of heart block. So, I guess I would, I'm more cautionary at
What's
times.
so great about the debate we're having is the same debate that has been had in Arlington at the CTS NET meetings, and hence has actually prompted a trial which is currently underway, a randomized prospective trial. So.
Yeah, and that'll answer a lot of
Absolutely, yeah.
Frank, what can you tell us about tricuspid regurgitation and mechanical support? I know that's been a debate that's been going on for decades.
Well, what is the rationale? The rationale in that situation is that when a left ventricular assist device is placed in the left ventricle and begins to unload the left ventricle, it could displace the septum, and that could worsen right ventricular function. So the idea being that you may not have tricuspid insufficiency, but with displacement of the septum towards the left ventricle, you might cause right ventricular dysfunction and new onset tricuspid insufficiency. So there's a debate in the field whether a more aggressive stance should be taken to trying to address even valves that are dilated but without insufficiency, to address ringing those at the time of LVAD implantation to prevent onset of tricuspid insufficiency. And quite frankly, the data, there's enough single center reports out there, and actually even from the STS registry on what to do, and it's very conflicting. And I think there's no consensus at this point as to what to do. Traditionally, what I've taken approach is if the evidence of right ventricular dysfunction, a dilated annulus greater than 40 millimeters, and any evidence of tricuspid insufficiency, I've taken a stance to perform an annuloplasty concomitantly with the LVAD implantation. Others don't, and I think really the information that we need is a more prospective trial looking at it. And I think the factors that come into that decision are pulmonary pressures, your pulmonary vascular resistance, what's the state of the right ventricular function, and obviously the size of the annulus of the tricuspid valve.
You could ask a technical point. When you do that, do you downsize the tricuspid annulus, or how do you go about measuring or trying to decide what's the most appropriate size of the annulus? I understand what you're saying with because you've already altered physiology and anatomy with the left ventricular assist device. How do you? What's your thought process?
I typically don't size the tricuspid valve. I place an annuloplasty ring of 28 millimeters, and I've had very successful results in terms of gradients doing that. So the measured gradients at operation tend to be 1 or 2 millimeters of mercury. Others would argue that gradient can work. You don't see what the gradient is in the setting of exercise, and that if you put a small annuloplasty ring, and there was some debate at the CTSN trial, what would be the minimum size ring? Some had argued for 26, but I think the final consensus was a 28 or 30 millimeter ring for that trial, and I think that's an appropriate range of rings to apply.
Pavan, in a patient who has a defibrillator or a pacemaker, does that change your strategy? Because that might reduce the chance of having a good technical result with just doing annuloplasty.
Yeah, I mean, I think we've all seen it. There's a whole spectrum of possible pathology that results from pacemakers, from having the pacemaker pinching or impinging one of the leaflets, with the leads going right through the middle of one of the leaflets. So I think at the end of the day, it depends on what that lead has done to the valve and where it's sitting. If it's sitting between two leaflets, I think oftentimes you can get away with an undersized annuloplasty, and I do very similar to what Frank has done, except I use a 28 or a 30. And I'll usually use a BSA of 2.1 as my cutoff, and below 2.1 I'll put a 28 in, above I'll use a 30. Okay. And I've been very happy with the results where I've undersized in that scenario. When it's gone through the leaflet is where I've noticed the problems and not having a durable repair. And in that setting, I've reluctantly but replaced. And in that setting, I will usually just impinge. I'd love to know what your practices are, but I usually take the pacemaker lead and just put it right to the side, right underneath the annulus.
Well, that's exactly what I do. I just sew a tissue valve primarily and just smash it up there. And remarkably, there's really very, very little leaking. Kevin, now that we have specifically designed tricuspid rings, is the DeVega type repairs of historical interest only, or are there any non-ring repairs that you would use in someone who really has functional tricuspid regurgitation?
That's been a great transition, because it's certainly been demonstrated that the DeVega repair or DeVega annuloplasty stitch will, in about 30% of those patients in the short midterm, develop significant recurrence of TR. So I've gotten away from any type of suture repair and just use all annuloplasty rings, except I say that with a caveat. If you have one of those huge annuluses that you can put your fist through, what I have done in those is done a DeVega annuloplasty repair to reduce the size of the annulus relative to the size of ring that I want to put, and then I'll place the ring over that. So it's kind of a belt and suspenders type of mentality, but I think if you just rely on a ring, sometimes there's so much tension in those great big dilated atria. So I will do a DeVega repair, bring it down to an appropriate size, and then place a ring over that. I have no data to back that up. It's just one of those the gray hair phenomenons as you proceed.
Yeah. Frank, do you have any special techniques that you use that might be helpful to the casual tricuspid repair surgeon?
Well, I think in terms of functional, obviously the most frequent cause for tricuspid insufficiency is functional, and largely in those cases that's addressed with just an annuloplasty alone. Where it gets a little more complicated is in settings of endocarditis, or where you have I assume the second most common reason would be trapped leads and leads that cause there. One technique that I found useful in those situations is bicuspidization of the tricuspid valve, and I think that's the sort of the go-to procedure for dealing with pathology of the valve itself.
Pavan, do you think there's any indication for excision of the tricuspid valve? You know, we fill out our STS forms, that's still listed there. Is there a reason to ever just cut out a tricuspid valve?
Personally, I think that's largely of historic interest. Interestingly, I've got 2 cardiologists who trained at Bellevue and love telling me about their experiences at Bellevue with drug addicts, where the valves were taken out and the patients did great. And they forget about the late follow-up and the RV failure that develops.
Or there wasn't late follow-up.
Right.
Right. Great.
Yeah, I would agree. I think that that's of historical significance. Probably back when we didn't have the antibiotic armamentarium and the sophistication of isolating organisms, back when, you know, the Pseudomonas and the very virulent type of organisms, and that's really all they had at that point. And I think, though, that with adequate preoperative antibiotic coverage, you know, then I agree. I would not just leave the tricuspid valve right open.
Really advances our ability to repair valves, and in addition, the tricuspid valve. So I think a larger and larger proportion of these endocarditis tricuspid valves you could actually repair, and then you don't have to worry about, you know, either a bioprosthetic valve that's going to fail, or seeding that valve with bacteria and getting recurrent endocarditis.
Yeah, and I think endocarditis is an interesting topic. I mean, it's endemic right now, and you know, I think, and I'd like to ask you guys, as I, you know, feel uncomfortable, but sometimes you do a repair, maybe a patch, and I'd rather leave a young 20, 30-year-old type of individual, maybe with mild, even moderate TR, as opposed to putting a bioprosthetic valve in at that time. Realizing that there is a recurrence rate. You hope to God that they don't come back and they get things straightened out. But that being said, what's your cutoff in regards to how much would you accept after kind of a complex tricuspid valve vegetation that you've taken out and you really don't want to put in a bioprosthetic valve, run the risk of a pacemaker and everything else in that type of a patient population? Do you do anything different?
No, I think in the face of active endocarditis, I do everything I can, including commissuroplasty, K-type procedures where we, you know, narrow the commissures. I'm happy to leave them with moderate to severe in the face of active infection, knowing I can come back later once the infection's cleared. A chronic situation caused by endocarditic destruction of the annulus or the leaflets, I'm more aggressive in reducing the amount of regurgitation. Great. All right, well, gentlemen, thank you very much. I think our time's up, and I hope our brief conversation has been of use to the audience. Thank you.